Presentation on methadone maintenance therapy in First Nations and Aboriginal people. My name is Roberta Crossman and I am a family physician and methadone provider based out of True North Medical Center here in Toronto. Just want to start off by saying that I have no conflicts of interest to declare. This presentation is updated from Dr. Sandra Sass's presentation that was done in 2011. Today there are 3 objectives. We will be discussing methadone maintenance therapy in First Nations and Aboriginal populations in Ontario and how it may differ from other populations. We will also be discussing some key statistics in this area. Lastly, we will discuss the many barriers to methadone maintenance therapy in this population, and we will also touch on some possible solutions to these barriers. In terms of methadone maintenance therapy in Ontario, I wanted to go over the timeline and the trend that we have seen for the number of providers and the number of patients on methadone. The CPSO hasn't released the data for the 2014 year, but we can still get a sense of the trend. In 2011, there were 379 methadone exemptions that were active in Ontario, and approximately 30,000 people were receiving methadone. This reflects a 15 to 20% increase from the previous year in terms of providers and patients receiving methadone. In 2012, there was a slight drop for the number of exemptions at 370 and an increase in patients receiving methadone to nearly 39,000. By 2013, there were over 40,000 patients on methadone, with 424 physicians providing methadone maintenance therapy. The difficulty with this topic is the lack of literature on methadone maintenance therapy in First Nations and Aboriginal populations. We are, however, increasing awareness of prescription drug abuse in this population. We also know that Aboriginal people are overrepresented among IV drug users in inner cities, and this is primarily based on a study done in Vancouver. There's also an overrepresentation at needle exchange and addiction counseling and referral sites, showing an increase in drug use by Aboriginal people. Unfortunately, we also know that the fastest growing group of HIV infections are Aboriginal IV drug users, and we will touch on this a bit later as well. We know that Aboriginal communities have had a difficult impact from opioid addiction. Substance use issues, and this includes drinking as well as drug use and other related harms such as violence and family disruptions, are consistently identified as priority health concerns by First Nations people. Nation's Regional Longitudinal Health Survey in 2010 indicated that respondents believed that alcohol and drug use was the #1 challenge to the community wellness faced by on-reserve communities. There are also some communities with a high percentage of elders, community members, National Native Alcohol and Drug Abuse Program workers abusing prescription drugs. As an aside, for anyone unfamiliar with the NNADAP, this is the primary network in place to respond to First Nations substance use issues. It was one of the first programs developed in response to community needs, and it evolved from the National Native Alcohol Abuse Program to a cabinet-approved program in the 80s. It's an example of a Health Canada program now controlled by First Nations communities, and its goal goal is to help First Nations and Inuit communities set up and operate programs to reduce high levels of alcohol, drug, and solvent abuse. It started from just 49 abuse treatment centers to now over 550 community-based programs. Although difficult to tell from the numbers and anecdotally, some communities report as many as 80% of adults abusing prescription drugs. And as previously mentioned, nearly a quarter of people attending safe injection sites in Vancouver are Aboriginal. Currently, according to the Drug and Alcohol Treatment Information System, in Northern Ontario, 299 out of 1,430 patients received opioid treatment in 2004 and 2005, which is just over 20%. In 2008-2009 year, 801 out of 2,895 received treatment, and that's an increase to 28%. This data doesn't include federally funded programs or other programs that may be in use for treatment, but it does tell us that more and more Aboriginal people are accessing opioid treatment services. As the rates of prescription drug abuse are rising, the Aboriginal leaders from Matawa First Nations and Treaty 3 have labeled it a crisis and feel it has reached epidemic proportions. In 2009, the Sioux Lookout First Nations Health Authority hosted a Chiefs Forum on the topic of answering the call for help, reducing prescription drug abuse in our communities. This included 3 days of presentations and breakout sessions to tackle prescription drug abuse. In the same year, Anishinaabe Yaqui Nation declared a state of emergency regarding prescription drug use, and worsening the health crisis, as previously mentioned, is that Aboriginal IV drug use has a higher prevalence of hepatitis C and HIV. There are a lot of challenges for methadone maintenance therapy in Aboriginal communities and many barriers, which we will talk about next. There is already limited access to detox, addiction treatment, and aftercare for opioid addiction, and we know that methadone maintenance therapy isn't universally supported within the communities or within some of the government funding programs. Some studies state the social harms related to IV drug use are overrepresented in this group, but methadone use may be reduced even when available. In Vancouver, just over 25% of people in a safe injection site identified as Aboriginal, but under 5% had ever used methadone compared to approximately 13% of non-Aboriginal people. So this shows that even if there is access within the city, Aboriginal people don't seem to be accessing the therapy as non-Aboriginal people. Also, currently, methadone maintenance therapy isn't provided through the National Native Alcohol and Drug Abuse Program. There are many, many barriers to methadone maintenance therapy. I just wanted to give an overview of what they are, and we will go into detail for each one of them next. The first is health in First Nations. We know through the media and through our own research that there are significant barriers to health, and this is everything from poverty, unemployment, lack of education. Resources are a limiting factor as well. There's a lack of physicians, pharmacists. It's difficult to recruit people because of the isolation of the community, and it's difficult to recruit people for addictions due to the stigma. There's also a lot of travel time and lack of colleague support within this area. In terms of dispensing, there's not only a limited number of rural pharmacies, but there's also an undersupply of pharmacists with training in methadone maintenance therapy. For funding, there's a lack of provincial and federally funded programs, and the cost, depending on what program you are funded by, can vary significantly for a week of methadone. For travel, we all know that there's a lot of barriers for travel even within the city, but especially in northwestern Ontario. Dr. Sass noted in her last presentation that there had been a patient that she knew that had traveled 3 hours one way to see the doctor, and then there's also the pharmacy wait time on top of that. In terms of stigma, there can be a lack of confidentiality in these small communities, and there can be a lot of perceived judgment or real judgment from people within the community. There are also a lot of misconceptions about methadone. Some people see it as not effective. Some people see the continued use as an issue, and this is a lack of education. There are also numerous other cultural barriers, which we will talk about as well. I want to go into detail a bit more about barriers to health in First Nations communities. The health status have had many barriers: poverty, unemployment, lack of education. These are a few that are not specific just to this population, but access to housing on reserves, overcrowding, and adequate water supply are specific to this population. As was popularized in Attawapiskat, many reserves across Canada don't have clean running water. Beyond this, there's a lack of activity and programs and issues accessing medical care. Nutrition is also a huge issue. It's so difficult to get fresh or healthy food on many reserves, and even if it is available, it may be too expensive for people to obtain. An enormous underlying issue, of course, is colonization in residential schools. I wanted to touch on this a bit more in depth for anybody unfamiliar. For some Aboriginal people, substance use is a way of coping with stressors and difficult life circumstances, and this can be the case for all types of people. A lot of this is rooted in colonization, where there was a criminalization of culture and language, creation of the reserve system with a huge, rapid cultural change, and a change from lifestyle from active to sedentary. There's, of course, systemic racism and forced assimilation of the residential schools, and this has led to lower socioeconomic status, poor nutrition, violence, crowding, and high rates of substance use. There are a lot of resource barriers to methadone maintenance therapy. It's difficult to get enough physicians, and it's difficult to recruit them. There's a lot of isolation. There may be compensation issues, and there's stigma of addictions even within the healthcare community. There can be a lot of behavioral issues from the patients. They can be very complex, and then there can be underlying mental health issues that some physicians don't feel comfortable to treat adequately. If a physician is willing to become a methadone maintenance therapy provider, there may be difficulty with getting the time, travel to get the license, having peers to review with. There may be a lack of support from other colleagues in your community, and some people feel there's a perceived lack of evidence and effectiveness in treating prescription drug abuse. Some of the barriers in terms of dispensing is that not all pharmacies dispense methadone. There's also an undersupply of pharmacists with this specific training. Along with this, maybe the willingness to dispense. It takes a lot of time, there needs to be adequate remuneration, and there's a lot of stigma to addictions, that these patients will cause a lot of shoplifting, and that your current customers may not want to attend your pharmacy if there's a lot of patients on methadone at your pharmacy. The hours of operation of pharmacies may also not be supportive to daily observed dosing. When a patient is new, they're going to be needing to see the pharmacist every day, so there can't be weekend or holiday closures. And if the patient is working certain hours, the pharmacy would have to be open at a time that the patient can still get their methadone. And then in some communities, the emergency rooms may provide a bridge for this, but they're not always willing or able to accommodate dispensing when the pharmacist isn't available. Funding tends to often be part of any barrier to addiction treatment, but there is a lack of funding for programs for methadone maintenance therapy. Non-insured health benefits cover the cost of methadone only for First Nations. It won't be covered for non-treaty or Métis people. NIHB will also pay for daily trips to the pharmacy for dosing, but only for 4 months. In order not to pay by this time, the patient would need full carries. This is inconsistent with current practice guidelines in Ontario. In some cases, patients may never qualify for carry doses due to instability, lack of housing, inability to safely store methadone. If the patient is on OW or ODSP, the cost of methadone is also covered. Funding is also often given after confirming attendance, and paying upfront may not be feasible for some patients. The Northern Travel Grant is only provided if the methadone provider has another specialty designation other than CCFP, which is for family medicine, which can be extremely difficult to find in a remote community as well. Methadone maintenance therapy is currently offered through OATC on some First Nations community, but many will travel long distances for physician appointments, their urine drug screening, and daily dispensing. And this is the case that Dr. Sass mentioned in her previous presentation, where one patient traveled up to 3 hours one way just for the doctor appointment, and then waited an hour and a half in the pharmacy. In terms of stigma, there's a perceived lack of confidentiality in small communities where everyone seems to know your business. The NNADAP worker or the nurse or the front desk staff could be your friend, or they could be your cousin or somebody that you grew up with. A lot of people have a fear of loss of employment if they're exposed, or a fear that Child and Family Protective Services may be called if they have carries, or if people know that they are on methadone and taking care of their children. There's also a fear of hostility or violence. Some people have a fear that their methadone may be stolen because it has a high street value. And there's a huge stigma in opioid addiction. A lot of people have stated that they feel that alcoholics are treated better. There's a long history of alcohol abuse in Aboriginal populations, and it's been studied quite extensively. And it seems to be more well known in the community that a lot of Aboriginal people can suffer from alcoholism. And some people feel that the same understanding and empathy isn't given to people with opioid addictions. There are a lot of misconceptions to methadone maintenance therapy. We find this across the board, and some of which can be quite dangerous to people's recovery. Anecdotal reports say that methadone is a specialty drug and it's for people who really aren't ready for treatment. Methadone maintenance therapy isn't part of the NNADAP despite the 4-to-1 cost effectiveness compared to other treatment modalities. Methadone isn't seen as effective due to reports of continued use and diversion, which does speak to a lack of knowledge about opioid addiction and the therapy itself. Anishinaabe Aski Nation Deputy Grand Chief Alvin Fiddler was quoted as saying, "We've heard that clients that were on this program for 10 or 11 years ago are given the same dose today. The effectiveness of the methadone program is under question." And this speaks to a lack of education about the program and the pharmacology of methadone. There are as well many cultural barriers to methadone maintenance therapy. In the community, as I've already stated, there's reports of approximately 80% of adults using illicit opioids. The NNADAP workers often work in isolation, especially in the remote communities, and there can be a lack of training and education. There's high burnout rates, and there's rapidly changing addiction challenges. There are also many cultural barriers. Some communities identify as traditional and some communities identify as Christian. The holistic model of health involves body, mind, and spirit, and methadone maintenance therapy doesn't meet this model. Also, substitution versus abstinence doesn't meet this model. And even if available, the treatment approaches may not be culturally sensitive, or they may not have as much community engagement as they would be needed to be successful. Other barriers are things such as lack of reliable childcare, transportation, having the funds to commit to treatment. Employment in these areas can be impossible with the time and travel constraints, and that may be a difficult choice facing some people. In order to overcome any of these barriers, it needs to be recognized that health is strongly related to the ability to fulfill your roles and responsibility, and feeling that you can't take care of your children or you can't maintain a job may impact someone's view of what is health. Methadone maintenance therapy is, however, increasingly being seen as part of an effective treatment for opioid addiction as we get more and more studies about its effectiveness, but it has to be culturally sensitive to be successful. It also needs to recognize that trauma contributes to addiction and mental health, and this is where a lot of the holistic approach may come in. Cultural practices also need to be the foundation. It can't just be methadone maintenance therapy, but also traditional medicines, sweat lodges, healing circles, and ideally members of the community should be part of the team, though we have discussed some of the confidentiality barriers with this as well. Stigma is prevalent in all levels of the community, from relatives and family and friends to healthcare workers and some physicians who don't believe in the efficacy of methadone maintenance therapy. As a substitution, methadone maintenance therapy is seen as less effective for some, and some people view it as morally wrong. It can hinder the recruitment of physicians and pharmacists, knowing that the community may not support this program, and it also is going to prevent people from seeking the treatment. And then, of course, with all of this, the funding is affected through stigma. We know that education is important for this. Education is needed at all levels to increase awareness of prescription drug abuse and IV drug abuse. And harm reduction, including substitution therapy, is an effective treatment. This may increase the readiness of the community and the band council level. We also need to increase skills in community resource worker, and this is child protection services, NNADAP, and mental health. Education is also important. Recently, the Canadian Centre on Substance Abuse completed a new technical competencies guide to working with First Nation clients. It's really helpful as it goes through a lot of the common barriers that groups will have when working with First Nation clients. And it provides a framework and brings in a lot of the cultural sensitivities that are important with this group. In order to help overcome barriers and burnout, support is really needed. There needs to be support for the frontline workers. This is the NNADAP, mental health, nurses, case managers, and the pharmacists and physicians. Ongoing education, collegial support, and mentoring programs help with supporting the community as a whole. There also needs to be availability. There needs to be a consistent funding system for all elements of methadone maintenance therapy, including the prescribing, dispensing, costs of the drug and travel, and funding for case management and social supports. When the funding is constantly changing, there can always be the fear that this treatment may be taken away from you completely, and there may be nothing that you can do about it. A lot of those are more long-term solutions. In terms of overcoming the barriers with shorter-term solutions, we know that lack of resources has been one of the long-standing issues with health in general in remote regions. Currently, with the Ontario Telemedicine Network, hopefully this will provide a short-term solution to some of these barriers. It's a huge help with the hours and distance issues. You can quickly train staff to run clinic from remote communities, and the only resources are internet connection, urine drug screens at the site, and a trained assistant. The references for this presentation are listed below. I hope that you enjoyed the presentation and took something away from it, and any questions can be forwarded to us and we'll do our best in answering them. Thank you.